Okay, so before we get started, I just want to give a little shout out to our artist in residence of the month. This month is Dr. Shivani Garg, who is an assistant professor in the Division of Rheumatology. And she does amazing artwork using coffee grounds as her media to supplement oil painting as well. I actually love her quotes here. So take the time to read. She has a website, I believe. She has displayed at art fairs, been featured in a variety of magazines. And this last quote I really enjoy. As a physician researcher caring for patients with lupus, things are rarely black and white. In those moments, coffee painting reminds me of the beauty in monotones and the comfort in embracing life as it is, while imagining what we can create from what we have. So I really enjoyed that. So make sure you put, oh, and here's some examples of her artwork. It's quite amazing. Yeah. So from that to screening and treatment of unhealthy alcohol use for cancer prevention, a clear, smooth transition. So I am absolutely delighted to have Dr. Michael Pignone as a professor, who is a professor of medicine at Duke University, and he holds multiple leadership roles there, as well as a long track record of leadership roles. He is currently the faculty director for primary care transformation and innovation. He's the director of the Collaborative to Advance Clinical Health Equity, and he is the vice chair for quality and innovation in the Department of Medicine. And prior to his arrival at Duke in 2023, he served as the inaugural chair of the Department of Medicine at UT Austin for 7 years. And before that, he was the division chief for general internal medicine and the director for the Institute for Healthcare Quality and Improvement at UNC. He actually did his med school and residency at UCSF, where we overlap, but have minimal recollections of each other. Michael has a long-standing research program that's focused on chronic disease screening, prevention and treatment, and improving medical decision-making, particularly in heart disease prevention, colorectal cancer screening, and the management of chronic conditions such as diabetes and heart failure. He's developed and tested interventions to mitigate literacy-related health disparities and improve the use of appropriate preventative services. He has influenced policies in the nation. He serves on the U.S. Preventative Service Task Force and has been a member of multiple national and international guideline and quality improvement panels. He's had multiple editorial roles, including currently an editorial board member for JAMA Internal Medicine and Journal of General Internal Medicine. And I think what impressed me most was his list of mentors in his CV, dozens, and how many of them have gone on to successful faculty appointments and research careers and leadership of their own. So I think that just tells you his commitment and his focus on service and improving the health of our communities, and focus on improving, training the next generation to do the same. So with that, delighted to turn it over.
Thank you. Thanks so much for coming this morning and taking the time. I'm looking forward to both doing this talk and also continuing some meetings I started yesterday with faculty members here. It's been great to see all the great work going on here in Madison, and really thanks to Dr. Schnapp and to Catherine Vaughn for facilitating my visit. It's a beautiful time of year and gets me really excited about all the opportunities ahead of us, even in this kind of tumultuous time. I'm going to talk today about unhealthy alcohol use. This topic is, of my things I've worked on, relatively new for me. So it's probably not as developed as when I give my talk on colorectal cancer screening, but it represents another example of something. I've spent my whole career trying to find things where there's relatively good evidence in support of a given clinical service, and we are not delivering it well. Okay, so I'm going to talk a little bit about some of the background information, some of the evidence, but then really spend most of the time talking about novel means of trying to go from maybe we should do this to here's how we might be able to do this. And then in doing so, overcoming some of the barriers so that we don't either induce or propagate inequity as we try to improve. I hope that's helpful as a framing for the talk. And I'm going to leave time for questions. I'm happy to talk about this topic or other related ones, at the end. So no conflicts of interest. My more detailed title, an underappreciated cancer prevention strategy. We entered into this topic during the time that I was in Texas, partly because we had, a ready source of support in Texas for cancer screening work. It has relevance beyond cancer screening, but I think particularly this is a useful lens for thinking about why we might intervene. So we'll start by talking a little bit about burden of disease, including cancer from unhealthy alcohol use. I hope some of that's familiar, but some of it may be a little bit new. We'll talk about recommendations for screening and then the evidence for incomplete implementation. And then I'm going to show you examples from two programs, one outpatient and one inpatient, where we have developed means for going from screening to recognition and treatment of people with unhealthy alcohol use from the work that I did in Austin when I was there. Sound okay? All right, off we go. So spectrum of alcohol use in the United States. And I thought a little bit about when I was coming here, this, if you do the I'm not going to actually do the state map. You do the state map, Wisconsin lights up big and red. And, there are definitely some features I think that, we need to pay attention to there. But let me just kind of give you the national perspective first. So about 86% of US adults have reported some lifetime alcohol use, but current use is actually declining. And 54% of people in the Gallup poll data from 2025 report current alcohol use, which is a little bit lower than it has been and lower than I think what most people perceive. So I thought that was kind of interesting. About 28% of people drink above the recommended limits, 2 drinks a day for men, 1 drink a day, greater than 1 drink a day for women. So a relatively large number of people fit into this category of potentially unhealthy use. Now, what I'm not going to do today is go into the really interesting, really difficult epidemiologic topic about whether low levels of drinking above those limits produces measurable health risk. I'll just say it probably does. It's really complicated epidemiologically. And it's actually not, in my mind, the most important topic that we need to think about, because most of the harms accrue to people with higher levels of unhealthy alcohol use, including the over 14 million, or about 6% of the population with frank alcohol use disorder, okay? So more of my attention is going to be in that space today. Here's the Gallup poll data. You can see this latest value. We'll have to see if that persists over time. I mean, I'm always, a little skeptical of one data point, but, it's sitting around 60%, now down to 54%. Perhaps, some of the many changes that we don't completely understand post-pandemic. And, here, this is how those trends have changed. So, decrease from 2023 of 8% on this 2025 data, and more decrease in women, more decrease in younger people. So is there really something going on here? And then I'll leave the party ID stuff at the bottom of that. I don't know or understand that one very much at all. So probably needs some more work by people who are, yeah. So here's my replacement of the state map, because I actually think state maps are sometimes, they oversimplify what's happening within a given state. So here, this is rurality and excessive alcohol use. And if you look at like kind of the gold corner here, that's high excessive alcohol use and low rurality. And then the kind of reddish is excessive alcohol use and high rurality. And you can see that alcohol use and rurality are not distributed across the country equally, and that we get up in here in the Great Lakes region, you see, at least a difference, especially contrasted with the area from, let's see if I can do this here, from North Carolina down over here to Louisiana, which gets its own special place. But this, highly Baptist and less alcohol use historically. So, definitely you need to pay attention to the drinking patterns in your area when interpreting this data. But I would say that here we have, certainly enough unhealthy use to warrant attention. And unhealthy alcohol use, I think, as you guys know, is associated with a range of health consequences. So this is data. Look at the most, to your side, right-hand column. So about 178,000 deaths in 2020, 2021 attributed to unhealthy alcohol use. A little over, probably like 2/3 related to chronic causes, including cancer, including heart disease and stroke. And then, of course, liver disease, probably the one that you would most recognize. But then also the number of acute causes. And for those of you who spent time working in the emergency room, you'll see this. We definitely did in Austin, the number of people with alcohol-related injuries, quite high, and some of them actually fatal. So I thought that was, pretty striking information, as well as, its contribution to other forms of death like suicide and motor vehicle crashes, of course. I'm not a basic scientist. This would be all the basic science I include, but there are, multiple pathways by which alcohol can cause cancer. I wanted to show these before I get into some of the epidemiologic data. So the conversion of alcohol to acetaldehyde, there's probably some like direct effects of that, increasing in oxidative stress, increasing or changing of the hormonal milieu, particularly estrogen, that affects some of the estrogen-related cancers, and then just its secondary role in the absorption of other carcinogens. So certainly for people who both use tobacco and alcohol, the risk is even heightened, particularly for the aerodigestive tract. Okay, so all right, that's my basic science. Back to my more comfortable epidemiology. So alcohol misuse is the third leading cancer risk factor after tobacco and obesity. I think it's much less recognized, certainly, than tobacco and maybe than obesity. It's a risk factor for several major cancer types. And I put them between the ones like liver cancer, where I think probably the average person can recognize that connection pretty easily. And esophageal and head and neck cancers kind of make sense on the pathway of, drinking alcohol. And I think where there's less recognition is the lower relative risk, but still relatively high absolute risk for common cancers like breast and colorectal cancer. And certainly this being October, it makes me think about, we have a huge amount of awareness about breast cancer generally, but as you can see from the graph on the right, probably lower level of recognition of alcohol as a risk factor for cancer and particularly for breast cancer. So in my primary care practice, I'm having those discussions with women before they enter the breast cancer screening age, where they just really ought to think a little bit about, that's one way to actually prevent breast cancer, whereas mammography, we're trying to detect breast cancer and prevent death. So a little bit more upstream potentially. The global burden is high. It is high and growing. It's obviously not distributed completely equally throughout the world, but here now we're talking about, about 740,000 new cases attributable to alcohol use. And again, across the same distribution, some of the cancers, particularly esophageal and liver cancer, particularly important causes. And just to get a little bit more specific, alcohol consumption among cancer survivors is probably lower than the average population, but still relatively important. So it looks like about 13% of cancer survivors are exceeding the moderate drinking limits I talked about earlier. You have a fair bit around the population average of binge drinking, and then just, more people in the, hazardous drinking, where this is going to be defined by scores on screening instruments that I'll show you a little bit later. So if you take care of cancer patients, you definitely are now in an enriched sample for risk for future cancers. And I think assessing alcohol use among our oncologists or other people that care for cancer is going to be an important thing. Here's alcohol use disorder again. much lower numbers here. You can see the second column's alcohol, but in the like 1 and 2% range for people with cancer types that are related to alcohol. So it's something that's definitely worth looking into. Okay, that's all I'm going to do for epidemiology. I hope I've convinced you this is a common enough problem that we should pay some attention to it, and as we deliver healthcare, and that there are some important consequences. Okay, so how can we reduce alcohol-related health burden? I'm going to talk mainly about the second bullet here, identifying and reducing risky and unhealthy drinking. But I just wanted to keep on the list and say a little bit about reducing overall alcohol use through policy changes, may be more cost-effective way to actually reduce population burden, and then certainly better treating the consequences of unhealthy use of people that have established AUD, and treating them also very important. So you really need to do all three if you want to have the most effective policy. I took a look at Wisconsin's state cancer plan. You have a very well-developed state cancer plan for 2020 to 2030, and it basically outlines three things: increase awareness of the relationship between alcohol and cancer risk. I think we've hopefully covered that already. Work on policy changes, number two, and then screen and treat people. So I think what I'm going to talk about is fairly consistent with your plan, and if you haven't had a chance, take a look at it. It's actually quite well done. Okay, so policy stuff for about 5 slides. So there are a number of evidence-based policy options for reducing the burden of unhealthy alcohol use. These include essentially means of restricting access to alcohol, including means of increasing prices. So you can do things like limit the number of places that sell alcohol, limit the time at which they are able to sell it, do more enforcement so that people that are below 21 have a harder time getting alcohol, increase the punishment for the consequences of alcohol, like drunk driving laws, and then raising taxes on alcohol. And I'm going to talk a little bit more about the taxes part, but I wanted to show you first, this paper literally came out like last week. It's from some of my colleagues from when I worked at UNC. So these are folks in the Gillings School of Public Health. And it was a national survey to ask people who themselves were current alcohol users, not necessarily misusers, about potential policy options. And you see here, they just gave a range of policy options. They didn't give a whole lot of detail about them, and asked, would you support, are you neutral, would you oppose? And basically what you see is very strong support for more informational interventions, like warning labels and restricting alcohol ads when children are likely to be watching, more information about the amount of alcohol in a given container, and then relatively less support for restricting access to sales or increasing taxes, okay? So I think that's the, at least a state of the current zeitgeist of the population, without too much more information about current, the actual current policies. I'm going to focus a little bit more on alcohol tax. I think this is kind of an interesting area for policy. So there is strong evidence that increasing alcohol taxes are an effective way to reduce drinking and reduce the consequences of drinking. So this systematic review, which was published in 2010, so it's relatively old, but I don't think the findings have changed much. So doubling the alcohol tax would reduce alcohol-related mortality by an average of 35%, traffic crash deaths overall by 11%, STDs by 6%, that was surprising to me, overall violence by 2%, and crime by 1.4%. In addition to bringing in more revenue that can be used for health things or other things. So pretty strong evidence of benefit. But what's happened in the United States at the federal level is there's been no change in federal excise tax for alcohol since 1991, okay? So basically, I don't know whether the rate was either the right rate in 1991 and we're at the wrong rate now, or whether it was felt to be too high in 1991 and we're at the right rate now, but it's big change. So $13.50 for distilled spirits in 1991. It's still 13.50 now, but that should be, if it was just inflation adjusted, twice as high. So you see that the nominal dollars coming in from alcohol taxes have gone up a little bit as the population's grown. But if you did, constant FY23 dollars, it's gone down considerably. So like that information wasn't included in that survey that I showed you. So I would just ask you guys to think about, from policy point of view, what should be the right thing. There's also like not exact parity between the different kinds of alcohol and the amount of tax per unit of alcohol, which again is kind of historic legacies, lobbying, things like that. So a lot of interesting stuff there. If you look at the state taxes, again, not consistency across states. Wide range of variation in the state taxes for alcohol, the excise taxes for alcohol. So plenty to work on. All right, that's all I'm going to say about policy. I'm not a policy expert, but I do have some interest and expertise in how you bring together policy and clinical interventions. And I think that's going to be an important question going forward for this area and many others. So now let's turn to the clinical side of things, screening and treating unhealthy alcohol use. I'm a primary care doctor. Much of what I'm going to talk about is going to be in the primary care context, but it honestly applies to every setting. And certainly if you're in GI or cardiology, you're going to see plenty of people that have unhealthy alcohol use, partly contributing to the problems that bring them to see you. So I hope this is relevant for everybody in the audience. How many trainees do we have here, residents or fellows? Okay, good. So, you guys are probably in the best place because you're still kind of figuring out your practices. So hopefully this information will be something you can take to heart. Okay, so the Preventive Services Task Force does recommend screening for unhealthy alcohol use in primary care settings for adults 18 and older. They don't make recommendations generally for specialty settings, so it's not like they're recommending against doing it in specialty settings. That's a B recommendation, moderately strong evidence, in favor. And the idea here is that you can accurately screen, so that's part of it. But then there's also effective interventions, and they don't make a positive recommendation unless the whole chain from screening to treatment to outcomes is, present. And then they also encourage pharmacotherapy for patients identified with likely AUD, but what the task force doesn't do is talk about how to do these things, okay? So we're gonna come back to that in just a minute. How to screen. Are you guys in your primary care clinics screening for unhealthy alcohol use now? Audit C or single audit C? Okay, so this is the question. 3 questions. These are all adaptations of the longer audit instruments that I'll show you in just a second, but the 3 questions perform very well as a screening approach. You see how it's scored. Positive is greater than 4, greater than equal to 4 in men, greater than equal to 3 in women. Well-validated approach. The single item screener, which looks at essentially the frequency of binge drinking, also performs well, but my feeling is most places are using audit C now, and it performs quite accurately. So good. That's not the hard part, parenthetically. This is the full audit, and I'm showing you this now not because I believe you should screen with this full 10-question audit, but we actually, I'm going to show you a little bit later, use it as a follow-up after a positive screen. And what it does, it has the same first 3 questions I just showed you for the audit C, but then it adds more questions that help you better sort people into likely AUD versus just unhealthy drinking without AUD. And while that's not perfect, I've actually found that it works pretty well in primary care to get a better sense about where on the spectrum of unhealthy use people lie. When I was in medical school, we were taught to do something that approximates a DSM-4 based interview. This screener comes from the DSM criteria, so it is essentially a more systematic or standardized way of doing that, and I found it quite useful. And then both the audit and the audit C, the score as it gets higher is associated with a range of outcomes, including all-cause mortality. So this is pretty well validated entity. Similarly, we have good evidence. I'm showing you here the meta-analysis that was used for the Preventive Services Task Force, that brief intervention can reduce alcohol consumption. So if you deliver a 1 or 2 session brief intervention, and I'll talk about what goes into that brief intervention in a minute, it is generally seen to reduce the number of drinks per week that people will consume afterwards. And also reduce the number of people who are exceeding the recommended drinking limits that I showed you earlier. And you can see from the meta-analysis figure, there's a lot of studies. It's a moderate effect size, pretty consistent results, and not all that much heterogeneity. Maybe some increased benefit for the people that are drinking at a very high level coming in. They tend to decrease more absolute number of drinks. So what would the brief intervention look like? So it can be as short as 5 to 10 minutes. Building rapport is really important, and I'll show you in a few minutes how we did that in the program that we started in Austin. It should follow the kind of general tenets of motivational interviewing, non-judgmental, build rapport, understand the patient's perspective, use open-ended questions, and then at lower levels of unhealthy drinking, it's partly about information, because you're going to run into some people, like, basically, if you just say, you're drinking more than is healthy, you should cut down, that actually works. And, great. If that's all you need, that's good. Kind of one step up from that, kind of keep track of how much you're drinking, do a little drinking diary, and then see if you can reduce the amount. That's essentially what we're talking about in a brief intervention, okay? And the importance there is that you probably need to do some follow-up to see how it did, okay? So I think that one session has been shown in trials to have some efficacy. I'm kind of more of a fan of a couple sessions at least. Now, you would say, like, how am I going to fit this in amongst everything else I'm being asked to do? And we're going to come back to that. I'm not sure that having every physician do this counseling is the most systematized approach that we can take. There may be other professionals on your health team that are better able to do it. But the other element where we really do need you guys to be involved is pharmacotherapy. So again, really good evidence that pharmacotherapy, particularly naltrexone and acamprosate, are effective for reducing cravings and heavy drinking in patients that have anywhere across the spectrum of AUD, okay? From what I call mild AUD to very severe AUD, okay? Yet, even in people hospitalized with the direct consequences of alcohol, our prescription rates are less than 5%, okay? Now, we could talk about, and I'd love to hear your thoughts in the question and answer about why do we have this huge gap? These are safe medications. They're far safer than many of the medications we prescribe all the time as internal medicine physicians. So I just really think there's a gap there. I just pulled this out of this recent New England Journal review done by my friend Alex Christ, who's at VCU. It's a really well done. He did it with Kathy Bradley, another expert in alcohol use disorder, and I would recommend it to you if you want to get up to speed on this topic more. But essentially, naltrexone and acamprosate, I use naltrexone for almost everybody. The oral form is inexpensive. Checking liver enzymes every 6 months is probably overkill. We've kind of overstated the amount of liver toxicity from naltrexone, and my colleagues that take care of a lot of people with liver disease have actually gotten much more aggressive about using it, but this is kind of the party line right now. If you don't feel comfortable using naltrexone, acamprosate works well. It's more expensive, needs 3 times a day dosing. You need to be a little bit careful in people with diminished kidney function, but again, very safe, much safer than many other medications we use every day. So how are we doing? We're actually doing okay on screening. So almost every adult, if you ask them in a survey, says that they've been asked about alcohol use. Whether they've gotten an evidence-based questionnaire, the numbers go down. So about a third report being asked about binge level alcohol consumption, one of the questions that comes up in the audit C. And then we do even worse of the people that do screen positive or meet binge drinking definition, only about a fifth of those were advised to reduce or quit drinking. So in the example I'm going to show you in a minute, we've been screening for many years and doing nothing with the results. And that, I think, is far too common. And then, like I said before, rarely utilizing pharmacotherapy. Here's some data from the National Ambulatory Medical Care Survey, basically saying the same thing. Very, incomplete use. So what are the reasons for suboptimal performance? I think one is stigma. We have all sorts of societal feelings that exist both in and outside the medical care system about alcohol use disorder, who gets it, who has it, who takes care of it. So I think that's one of the differentiators here for this topic. For this topic and for every other one that I deal with in my preventive care research life, competing demands, we've got a lot of things on our plate, including whatever the patient came into the office for that day, their other chronic problems, right? So that is a real thing. We haven't probably emphasized this topic a lot in training, and we haven't necessarily built out the multidisciplinary teams to do it well. When we do detect unhealthy alcohol use, we've tended to refer treatment out, and then between stigma and barriers to getting into that treatment, which may be access to care, it may be transportation, it may be the fact that insurance has tended to oftentimes carve out substance abuse treatment, that becomes a problem as well. So a lot of things going into why we're in the position we're in. And I think, as you can tell, I'm making an argument we need to bring this back like any other chronic disease and treat it more like other chronic diseases. So what can we do? All right, 2 programs. I'm going to tell you about the outpatient program and then the inpatient program. This one is published already in JGIM, so if you want to read more about it, this is the picture of the article. So this work was done in Central Texas, which is where Austin is. The FQHC system, the Federally Qualified Health Center that we worked with, is a big FQHC in Austin. It has 22 sites, over 120,000 patients, so big system. We focused this work initially on one site, the one teaching practice that has both family medicine and internal medicine residents in it. So probably not incredibly dissimilar to your teaching clinic here, heavily Latino, heavily Spanish speaking. So that's maybe one difference. And like I said, they were doing pre-existing screening, lots of screening, doing absolutely nothing with the results. So the approach that we developed was designed specifically to overcome some of the barriers I talked about earlier. So we continued screening. They were screening with Audit C. That's fine, not going to change that. But then we wanted to have a workflow where those that screened positive would be referred to one of our team's bilingual social work trained counselor navigators. And we implemented this whole system under telecare. Parenthetically, we were not sure whether we were going to use mostly telecare, mostly in-person care. When we wrote the grant, it got funded, the pandemic started, and fortunately, we had planned for that as one of the modalities. And we went to that as the exclusive modality. So all the care was done via telecare. And that may seem hard, but our social work trained counselor navigators were so good at establishing rapport that I think the benefits that came from being able to easily get in touch with people and have multiple sessions overcame some of the barriers to not being face-to-face. So I'll leave it to you to think about pros and cons. Probably you should have both options. And then, like I talked about earlier, we really wanted to do a straightforward risk stratification. So if you had a positive screen, you got the full audit. If you completed the full audit and your score was low, so that you were in the unlikely to have AUD, mostly just drinking above the recommended limits, you got our brief counseling sessions, and then we basically said, that's good. If you wanted more, we would give you more, but we didn't compel people to get more. If you had a higher score, we still delivered the brief intervention, which probably isn't exactly evidence-based, but it turned out pragmatically to be very important because it's how we built rapport with the patient. So you still started with the same intervention, but then hey, I'm not being able to cut down on my alcohol use because I'm having intense cravings. It opened the possibility to do more. So there we then partnered with the physicians in our team to recommend pharmacotherapy, mostly naltrexone, and also to offer additional counseling, both with our social work trained counselor navigator or through referral to community-based resources like AA or through referral to higher levels of addiction care. When we wrote the grant, we had originally planned to collaborate with addiction psychiatry for the patients that had more complex presentations. That failed miserably. They had no capacity. When they did have capacity, we couldn't get patients to go there. So we pivoted from that. And at that same time, our practice hired a primary care physician trained in addiction medicine who acted as our clinical champion and took care of the more complex cases within the same practice. And that worked better. Then our goal was to reassess the audit at 3 to 6 months to make sure we were seeing the changes in audit that we would have expected. This was not a randomized trial. We were just using this as like, do we have some signal that things are going in the right direction? Yeah, like I was saying here, so before and after single group, and then we wanted to look and make sure there weren't demographic differences, that we were reaching some people better or less well than others. So here's just some of the data from our one site. So, about 14% of people screened positive. About 2/3 of those were on that very low positive, audit C score of 3 to 5. And then, the remaining 40% were higher scores. About 10% were scoring the highest level of audit C. And you can see here, men more likely to screen positive, Latino folks less likely to screen positive, and then commercial insurance more likely to screen positive. So there's the patterns of health disparities in alcohol use don't look like your more common health disparity issues. It's a little bit more complicated, okay? I'm not gonna go through this here. I just wanna say this was kind of our flow diagram. You can see it in the article, but we had very high fidelity with getting people their counseling, reasonable fidelity with getting follow-up audit scores, about 60% completed audit scores, and our initiation of pharmacotherapy was not 0, but it was below what we had targeted. So I don't think we've totally cracked the nut on how to get people with very high audit scores who are not getting better pharmacotherapy, and that's kind of, our ongoing work is in that area. Overall, people had about a 4-point reduction in audit score. That reduction was larger for people with higher initial scores than people with low initial scores who can only go down so much. And we had relatively small differences by demographic characteristics in the likelihood of having a decreased audit. If anything, our Spanish-speaking patients and our Latino patients and our African-American patients did a little bit better than our white patients. So we were not inducing some of the typical disparities that you might see. So no control group. This was not designed to test the efficacy of brief counseling. We believe that had already been established, but at least some data suggesting that things were going in the right direction, albeit with incomplete assessments. And then, we really need to look at longer term outcomes. This is really a 3 to 6 months, and whether these, changes persist over time, not sure. But we did feel like implementing screening and this brief telephone-based intervention was feasible in a very diverse patient population, and that we were not inducing disparities. And, at least some recognition there's still more opportunity to better improve pharmacotherapy and counseling. And then, right, this is one practice out of a 22 practice system. We need the ability to spread. And frankly, the policy environment is not such that that is easy to do. So one of the things that I'm trying to work on in my new position is working from the policy side in addition to the health services research side, so that when we do have successes like this, we don't have to beg, borrow, and steal to fund the work. Our social work trained navigators are very capable of doing this work. We just need to find a way for them to be reimbursed for their time at their appropriate wage rate. So this is some of the members of our team. Mary Velasquez, who's down here in your bottom left, was one of the national experts in brief interventions and is in the School of Social Work. She's a psychologist. But having her on the team really helped us, I think, with our training of our interventionists. Karen Mendoza, our main interventionist, was just amazing and has moved on to a supervisory role. And then, we had good support within our FQHC system. Matt Hubley was chief resident and became our primary care champion, helping to socialize these changes to our residents. And then John Weems, our addiction medicine trained consultant, really key person. Jocelyn held the whole thing together. Okay, how are we doing on time? We are, okay, I'm gonna try to go a little bit faster here. All right, that's one spectrum of the population. Now let's move to the hospitalized patients. So this work was done in our Safety Net Hospital in Austin. It's a level 1 trauma center, and also the hospital where the people in the practice I just talked about would be most likely to be hospitalized, okay? So here, what's the rationale for doing the same work in the hospital setting? Well, people who are hospitalized, there's a teachable moment, particularly if they had an alcohol-related admission, and I'll show you a lot of them did. A good place to start medications and make sure people tolerate it. And then, the acuity curve is shifted up. So we're gonna see more people with alcohol use disorder. What, is probably speaking against that is then you still have the issue of transitions, right? And we know that, I think, like I said earlier, 2% of people with AUD had a prescription at discharge for people hospitalized with alcohol-related hospitalizations. Okay, enough about that. So this is a it's not a big hospital, 225 beds. Medicine was about half those beds, so we typically took care directly of about 100 patients. Level 1 trauma center, so part of their trauma center accreditation involves screening for unhealthy drinking, but again, they had not done anything with the results. They were dutifully recording it, but not acting on it. There's a consult liaison psychiatry team, but no addiction consult team that would treat alcohol use disorder at the time we started. We had developed in hospital medicine a successful opiate use disorder identification and treatment program called the B team, which we'd published on previously. So at least some prior proof of concept that we could do this, but nothing for alcohol use when we started. So we continued screening. Again, social work trained counselor to assess positive screens, brief intervention for everybody, pharmacotherapy for the audit greater than 12 population, and then transition to care. So here, we ended up successfully screening about 2/3 of the people who were admitted to the hospital, okay? Missed people that had short stays that were weekend only, I think probably more, or where they were in the ICU most of the time. But again, about 6% here screen positive with the audit PC, which is a little bit different instrument. It's the instrument they were using. So now 5 questions rather than 3 questions. And ended in, how often during the last year have you failed to do what you normally expected because of your drinking? And has anyone ever been concerned about your drinking? So a little bit more of the consequence-based side of things. Here are the demographics of the people that screen positive, overwhelmingly male, mostly middle-aged, and then more white than Latino or African-American, a little bit out of proportion to their overall population. Our unhoused population was relatively overrepresented, not surprisingly, as were people that were uninsured. And about a little over half of the admissions had alcohol use as at least one of the contributing factors. So when we did the full audit on folks that screened positive, 60% of the people had that audit greater than 12 that is more suggestive of AUD. And we engaged almost everybody who screened positive in the behavioral intervention and started, about half of the people, who we had brief intervention with on medication. We assessed about a little over half of the people and started a little bit less than half of the people, 228 out of 641, for a variety of reasons. And we got follow-up information on a minority of people after discharge. So about 60% received some form of follow-up. About half of those we reached by phone and got a follow-up audit on them. And the ones that we did reach and got follow-up audits on, almost everybody showed reductions. And you can see here the reductions in the audit score, albeit in a selected population, were quite large. That paper is out at journals now, so hopefully will be published soon. But I do believe it demonstrated we can feasibly implement screening and intervention for hospitalized patients. We tried to focus most of our energy and follow-up on the people with AUD. And even then, the transitions of care became challenging. And we need probably even more work to facilitate those transitions of care. But for the people that got prescriptions at discharge, that got some degree of follow-up, their reductions in audit scores were pretty remarkable. Here's our inpatient team. Some of the same members, John Weems also on the inpatient team. Jan Ramesh is here. This is her first large grant. She's a hospital medicine physician. Chris Moriades, a very experienced hospital medicine physician and researcher, helped with this grant too. So it was a cool collaboration with some of the same folks, as well on the outpatient side. All right, good. So we've got time for questions, but I just wanted to kind of finish up, put the whole thing together. So I think, I hopefully have demonstrated to you that screening and risk stratified treatment is effective, remains underutilized, but using a team-based approach at least has been demonstrated to be feasible, effective, and relatively efficient. I didn't talk a lot about cost, but by distributing the work in a more diverse team, it's less expensive than a physician-centric approach. But there's still a lot more work that needs to be done to disseminate this approach. We have funding, fortunately, through the Texas Department of Health to do work like this at other hospitals, particularly less resourced hospitals throughout Texas. Some of that funding was cut recently with the new administration because a lot of it originated originally with SAMHSA. So, we're not immune to some of those stressors, but I've been pretty excited about the work going forward and would love to hear if any of you all are doing work in this area here. Love to hear about what you're doing as well. So thanks. I'm happy to answer any questions, and please sign into the session evaluation and, hopefully give me a decent mark.
Thank you. We'll open up for questions while the thing is coming down. All right, Farah, I'm gonna run up.
Morning, nice to
Hey,
see you. I'm just wondering with the pharmacotherapy, how frequently patients refused it and why that might be an indication for the low numbers.
My sense, I don't have the data in front of me right now. My sense is that there were a number of people declining. I think the idea, we've really, like I said earlier, we have all kinds of societally mediated feelings about what addiction means, what alcohol use means. And I think it is not a small step to acknowledge that I'm having enough trouble with cravings or how my drinking behavior is affecting my health that I need to take a medication. So, I have people struggle with taking medications for all sorts of more mundane, unstigmatized conditions. So I don't think that's going to be ever like 100%, right? I think and hope that in the context of a ongoing relationship that's trust building, that it will happen over time. But I also know we're operating in a system there in Austin, probably here too, where there's a lot of discontinuities and a lot of other stressors that make those relationships challenging to develop. I think what I would like to have happen, this may be more answer than you wanted, is we've got to get out an either or thinking. So I'm not big for like the only way you can treat alcohol use is X. Like I think we have to have a menu of options, some room for shared decision making, and ideally sometimes combining approaches that haven't necessarily been combined before. So I didn't talk a lot about it, but we've also partnered with peer support coaches to meet patients in the hospital and then be available to them as a resource. I think that probably needs to be strengthened. And we've just got, we've got to get more of our sites ready to be catchers of patients out of the hospital Because a lot of our patients did go to the clinic where we've already implemented, but a lot went to other settings too. So big challenge.
Just to go off of that a little bit, one thing that I noticed in your data that you didn't touch on is that we never asked if people were willing to change or if they wanted to change. In smoking data, I think that that's a big factor. If they don't want to make a change, they're not going to. And I'm just wondering if that same connection probably happens.
Yeah, I think, stages of change apply here too. And I didn't talk a lot about, and probably am not the best person to talk about. You probably should ask Karen Mendoza about how those conversations go. I think there's some element of the intervention that is informational. And then what happens after that totally depends on building that rapport and that tension, that resolving contemplation like we would with tobacco, where some people are going to be interested in doing more and some people are going to be not as interested at that time, which doesn't mean forever, right? Like sometimes it's like we just need to keep building rapport. And I think the challenge is the people, particularly on the inpatient side, that were having more severe consequences. There is like an element of you'd like to move faster. But very, very important point.
Thanks. I think your talk brought up a lot of challenges that we are all facing. One in particular is the transitions, right? It's not just transition from inpatient to outpatient, but it's transition from me as a physician to my APP, to the health coach or the social worker. And I feel like even when we do warm handoffs, patients get lost. There's a lot bigger team, a lot more people to communicate with. But it's the future. I think it's where we need to go. But how do we overcome those challenges and really help patients feel centered?
Thank you for highlighting that question. I hope it was implicitly in there, but I want to say it explicitly. That is a skill we need to teach, study, and iterate on. So the idea like, all right, this is important enough. We need to really understand exactly how to do this well. I'll say in my own anecdotal experience, I think it is really important that you have multiple reps with the same person you're handing off to. So if I'm handing off to an impersonal call center, I can't really, like I say, like generally it's great to talk to somebody about your alcohol use or smoking. But when I say like, I want you to meet my colleague Karen, she is really good at this and you will really like her. Like it overcomes some of that gulf. And I think we've just got to get better. And we also have to get better at how do we select people that enter into these fields? Like, how do you select for the person that's going to be easier to move up the trajectory getting good at counseling? I don't think for any of the counseling things we do that we've done that very well. I think to myself, like, I ran a big trial of heart failure self-care, and the person who was doing the self-care training was like the best person I've ever worked with in this area. And if you looked at her on paper, she looked just like the next person. She'd done nutrition, counseling, training. But after she moved on to another position, the next person had, if anything, better credentials, but was just terrible at it. She couldn't build rapport. And like, I don't know how we figured this out, especially in an area where like having factual information about the calories in a given food item aren't actually the secret sauce, right? We can look it up. So if you guys have any thoughts about how we can do this better, I'll just say, like, I mean, I do think the continuity of relationships is really important for building those reps. So.
Thanks for the talk. It was really interesting. I kind of have a follow-up question to that, kind of with the transitions of care. So I thought it was interesting when you said in the outpatient setting that people were really not wanting referral to the addiction psychiatry folks. And I was interested to hear, did you have a reason behind that in terms of, was this like a social determinants of health, like travel issues, or not wanting to speak to somebody else because of stigma?
Both of those things, and just plain lack of availability. Like,
yeah.
We will only have one session every 2 weeks to see your patients at X time. And, so it just exacerbates all the other things. their practice is really, really on the far end of the high acuity side, and they were not set up to take on the what I'd call mild to moderate AUD folks, people who hadn't progressed with a brief intervention and needed more. So, and maybe that's rightly so. Like maybe they do need to focus on the people who are really at the extreme end of the spectrum. But it said to me, like, I really like the idea of embedding specialty care in the primary care practice. And so having more hospital medicine trained and primary care trained addiction specialists, I think is the way to go. And maybe they talk to someone with even more depth of expertise in addiction psychiatry, but I'm not sure that moving humans between settings is the easiest or best thing for all those reasons.
Yeah, I think most of our experience, especially on the inpatient side, is at the VA here, and we get kind of the complicated cases, but most of our psychiatry colleagues admit the uncomplicated patients in that way. So I feel like a lot of the times, we're not always seeing that, but like transitioning from their specialty care to here is a big barrier for them too. So
Yeah, it's interesting. We have these different routes and almost like different referral streams. And I did an addiction psychiatry rotation as a medical student at the San Francisco VA, and it was amazing. But it was like a different spectrum of patients than I was seeing in my primary care practice. Kind of. I mean, there were some commonalities, and I just think we need to collaborate more. The idea that we put all of one type of expertise here, all of one type of expertise here, as opposed to having a more distributed model just doesn't make sense to me.
Yeah, so one reason that I often don't prescribe naltrexone is due to transaminase elevation. So what degree of elevation would you feel comfortable?
I'm probably not the best person
Okay.
to answer that.
Yeah.
I think the answer is it actually doesn't really matter, but I think we need to have some better studies. And because there's so much alcohol use disorder in people with liver disease that is alcohol related, MAFL related, or both, this is something we got to get figured out soon. But what I'm hearing from my colleagues who work in hepatology is increasing comfort with prescribing, if you're not in florid liver failure.
So much. And just one more question kind of directed at Dr. Miller. So from a resident standpoint, I don't think I've ever seen an audit come across my computer. So I have no idea when are we screening?
To your point, is like we don't even realize it's happening, and our patients are getting screened, but I hardly ever pay attention to the data myself personally. And I actually review all of the patient comments for general internal medicine every week. And at least once a week, there's a patient that makes a comment of, I was asked these questions, I told you I had depression, and my physician or clinician or provider never asked me about it in my visit. So it's definitely an area we need to improve on.
Can I tell you a brief story of a mistake I made that I think will kind of it helped cement home for me why this is important. I took care of a guy when I was in North Carolina and had a primary care practice for probably 10 years. And he was a really nice man, lived a fair bit of distance away, but always came for his visits and always was hypertensive. And I had him on like a 4 or 5 drug regimen. He was not someone who was big at self-disclosure. I think I probably recognized that, but I never asked him. And I asked him questions where he could have disclosed, but he didn't. But I never asked him explicitly about his drinking. And then finally, someone else, I think it was a resident, in fact, asked him, and he admitted to a high level of drinking that ended up causing some problems beyond the fact that he had not well-controlled hypertension. And I just said to myself, like, I put him in a box, like, because again, in that area, people like him demographically did not drink at a high level, okay? But that's not, applicable on an individual basis. And I spent a lot of time messing with his hypertension meds that I probably could have gotten to that. And like, frankly, had a lot of opportunities to help him that would have extended his life. And so that one just resonated with me. You can't just wait until it hits you in the face to address it. So anyway, hopefully you can learn from that example and, find some of the folks that maybe aren't going to disclose on their own and engage them in treatment.